So I am talking about employee engagement and how a project that we did with our fluoroscopy team had an unexpected bonus benefit of affecting our outpatient satisfaction scores. And so I really want to talk through the tools that we use in our department to engage with our employees, because if you feel like they're not as engaged as you would like them to be, then I want to send you home with the tools that we use to be able to engage with everybody despite, whatever generation they're in. These tools work universally to be able to connect with your employees and to have them generate the ideas and be a part of the solution to whatever issues you have going on. And that helps create more employee engagement amongst the team, between your relationships. So we are going to spend quite a bit of time using lean management tools and ideas and going through those. And then I will progress on to what our specific project was and the results from that. So I'm going to try and keep up with both computers at the same time because I've got my notes over here. So our objectives today, we're going to learn about the lean management tools used in our departments to empower and support our teammates. This is where I'm going to spend the majority of the time going over those tools. Agenda item number 2 is about our weekly huddles, which is one of the tools that we use. And we use our huddles to generate ideas for improvement and to check in with the team. So I'll go through how we do that. And then number 3 is how our teammate engagement positively affected outpatient satisfaction scores at our specific facility at High Point Medical Center. We are in High Point, North Carolina. We are a 350 bed community hospital. We are part of a much larger organization, and our flagship hospital is an academic medical center. So lots of diverse workflows that don't always carry over from one facility to another, but really it's connecting with our teams and getting all of those ideas from them. So our lean management training at our facility is led by our COO, and lean management is his passion. And he has put together a group. It's an open invitation to anybody who wants to come and learn. And the name of the group is called Embedded Coaches, because that's really what he wants the goal to be for the group. So he wants to embed throughout the hospital building a group of people that have competencies in lean management tools to be able to assist in performance improvement projects and change management projects as they come along. Because we're already familiar with their tools and the terms and how we're going to go about this, it makes for a smoother transition when we have big projects come along. So it's mostly a group made up of leaders in the building, but it's not limited to that. If there's a frontline teammate who has the ability to step away for an hour and join us, they're welcome. It's really anybody who wants to come can come. And then as a part of that group, we're discussing whatever change management thing that's going on. Hey, come on in. Whatever current projects are happening, we'll talk through those, see if the folks that are leading those projects have any concerns or get an update on those projects. And then we will do re-education every so often. So we'll go back to the basics and go back over the definitions and go back over the tools that we use, because there's constant turn in the group. For new people are always joining. And so we want to make sure that we're all speaking the same language. Everybody knows the tools that we're talking about. And so we'll go back and do re-education. It helps keep everything fresh as we're going through. And then as part of the group, we earn points depending on what types of projects we're on. If you're writing an article for, your specific, like if you're a nurse, you write an article for a nursing magazine about a project that you did. points are associated with that. If you lead a big change management project, points are assigned to that. We also give points for just attending a meeting. And so that's how we engage with the newer members of the team. It's, their first 6 months as a part of the group versus the folks that have been a part of the group for several years. And attendance points cap out. You can't, accumulate all your points from attendance, but it's how we are able to establish competency in some of these things with the goal of helping other departments with their projects. So if there's a newer leader who isn't well versed in lean management tools, then somebody who has more points from the group will be assigned to that project as a help, as a resource, and to help the project move along smoothly. So some of our projects are assigned. He'll say, the COO will come up and say, okay, this is a project that we need to start. This is who I want on the team, and he'll name names, and then they're able to pull in key stakeholders as needed throughout the project. But when teams are assigned like that, it's usually something really big, and it's always, there's one or two folks that have nothing to do with the workflow that are assigned to the team to give a fresh outlook on the situation. An example is blood consents. We recently had a big project on blood consents, and so that's heavy nursing in that because that's who does that workflow. But we had folks from other departments like pharmacy who have nothing to do with blood or blood consents in the team, because if it's your workflow that you do every day, you take certain steps for granted or certain parts of the process for granted, and the folks who aren't in that and living it every day don't. And so they're asking the questions, well, why does it have to be done that way? What if can we do it a different way? And it gives you a good perspective that you wouldn't have thought of, because you're like, well, I mean, that's just the way we do it. And part of the change management process is to really break all of that down. So we are empowered to own and run our own department. And any projects that come along that we want to do, we can just do. Knowing that as a part of this team, we have resources, we have help. If we have a question, we can reach out. There are performance improvement advisors in the system that we can reach out to. There are a couple on our campus, but I've worked in a different organization where all of the big projects had to include that team, and it had to fit into their schedule, which is great to have their help and their resource to rely on. But if I have an issue right now that I can handle and run a project on right now, then I don't have to wait for it to align with their schedule. And so we're able to go ahead and own that, and then bring it back to the group and report on that and give an update where we are. Are we hitting any hurdles, and brainstorm ideas as a part of this group? And then, we just adjust as needed. So it's really a great system that I wanted to share because it works well. There is an internal certification. We get a certificate. So after you earn a certain number of points, you are an official embedded coach. And then from there are different point thresholds for a bronze, silver, and gold embedded coach. So it really showcases competency level and who can handle what kind of project. And so, these are not all of the lean terms. I just picked some of them. And so we'll go through those because I won't spend a ton of time on all of them, but these are the tools that we use in the department to check in, involve the employees with when they bring forward a concern. These are the tools we use to implement on how we're going to solve those concerns if it's something big. So part of our leadership team has created a corner in our hospital homepage that has definitions. It's got templates for an A3 so that you're not having to recreate that. It's already there. All the boxes are labeled with instructions and notes in the file. And so it's really, if you're not familiar with lean, these words don't mean a whole lot. They're not self-explanatory. And so that's really why we go back and re-educate the newer folks in the group and go back over it, because 5S doesn't mean anything if you don't already know what it means. And so they're all tools that you can use to engage with your teammates to go through and observe, what the problem is. And then tools you use to work through potential solutions. So an A3 is essentially a systematic way to organize a big change management project. It's called A3 just because that's the size of the paper it was designed to print on. And it's a series of boxes that you work through in order. And that's the hard part. Because one of the early boxes, the first box is really making your problem statement. What is the specific problem that you're solving? And it helps define your project scope so that when you're working through it, inevitably people are like, yes, but what about this other issue? And you can really circle back to, well, that's not really in the scope of this project, but we'll put that in the parking lot and get back to it later, to really help keep everybody on task for the project. And then the other thing that A3 does is it forces you to go box by box, because once you identify what the problem is, inevitably at least one person in the room, because we're all problem solvers, it's what we do. We don't even think about it. An issue happens, like I got a text, please come back to MRI, it's raining inside. So there's no process for that. I just got up, started texting, sending messages like, please send engineering up to MRI, it's raining inside. And it was, a heating coil had ruptured and it was chaos. There's no process for that. I have pictures. I can show you pictures after. It was raining out of the smoke detector. I don't need a process for that. That's immediate action, instant solution. You get up and you go and you do. And A3 is not that. So inevitably, once you get your problem statement, then somebody's going to go, but I know how to fix that. We can fix it by doing this. And so you've got to politely tell them to hold on, because we're not in the future state process map yet. We're not in the solution generation box yet. We still got to work through all of the other boxes. So I printed our template out. I changed the size of the boxes because I don't have a printer that prints A3 paper. So I made it fit on legal size. So if you guys want to see that, I'll pass that around. The template has the boxes numbered, so you start at the top left and work down vertically, and then move up to the other side and work down. And it really helps keep everything organized so that you know what you're going to work on, what boxes you're going to cover in your project planning meeting, because you don't go through all of it in one day. And you can have key stakeholders for the boxes that you're going to be covering in the meeting when you need them. And then if there's meetings that they're not going to be involved in, you're able to free up their time and only have the people that you need at the time for whatever it is you're discussing. So it's a great tool, helps keep everything organized, everything in one place, and helps keep you on task so the project doesn't snowball out into something it wasn't meant to be. Yes.
Maybe everyone knows, but I am not familiar with lean. And so the terms, you're right, mean nothing.
Mean nothing.
So could you just, is that something that I should look up, or?
No, I'll
touch on that to explain?
Thank you. Yes, so
Okay.
lean is really, I don't use the word lean with my teams because it tends to have a negative connotation of, okay, we're going to go through some lean management tools. They hear, I'm going to start chopping things, and they're going to have to start doing without things. And that's not what it's about. It's about efficiency, and it was designed by the Toyota production system for their production line in cars. And how can they consistently achieve superb results every time, no matter who was on the floor? And so standardization of work is huge. So you have a process, and it's not so that everybody has to do everything exactly the same way, but when you're confronted with whatever issue, the team is familiar with, when this happens, this is what I should do. This is the process that we do. And it helps them, because when a surveyor says, well, how do you know that this happened? The answer is, well, that is our standard work. We do that for every patient every time. Just like using 2 patient identifiers, that's your standard work. You check 2 identifiers every patient every time. And so you use that in your workflow. So if there's, something that is hit or miss, you have an issue that's hit or miss related to workflow, then you can bring your team together and brainstorm, okay, what do we want our standard work to be? And it's not me prescribing it, because that's not going to engage the team. It's bringing it back to the team going, okay, here's our issue. What are your thoughts on how we want to build this so that it works and makes sense for us? And that was really hard for my team at first. When I first joined, I've been at this organization for 4.5 years. And when I first joined and I started asking them, okay, well, what do you want to do? They're like, well, I brought you the problem. That's what you do. I'm like, well, yes, okay. And I can solve the problem. I have an idea right now that'll solve the problem. However, I'm not the one that's going to have to live it. I'm not going to have to do it. I'm not going to have to deal with the results of it. It's your workflow. You're the one that's going to have to do it. And so you have perspectives about how the work gets done that I don't, because I'm not doing it. So it makes more sense for you to help come up with potential solutions. We can discuss and pick one, and then try it and see what happens. And that's how you get them engaged. Because if you do that repeatedly over time, they see that you're interested in their thoughts and how the work should get done, and you value their ideas. And when they see their ideas be implemented and that you take that seriously, then it builds their ownership in the process and their ownership in the department, and they know that you value what they think.
So this is not on the level of just leader to leader. This is, you're allowing your employees
Yes.
to own their problem,
Yes.
resolve it. Are you doing it on paper, or there's like, do you have to do a formal, or is it just,
No.
you just have them think through?
Yes. So we only use the A3 for a big project. If there's something simple of, hey, we ask, what's getting in the way in huddle? What's getting in the way of you doing your job? And one of the examples the COO will share is at one of his facilities when he was a director, the schedulers wasted a lot of time because they would have to print something. Then the printer's not next to them, it's across the room. So then they had to get up, walk across the room, go get it, bring it back, and then deal with it. And they're like, we get up and we walk all day long. Can we please just move the printer? And he's like, yeah, just move the printer. It can be that easy, but they're solving their issues. And that's really what you want to get to, is how can you say yes to their request to solve the issues that they're running into in their daily work. And you can't say yes to everything. Sometimes there's things that you can't do that for, but you can explain the why. And then that helps them then shift into, okay, well then what can we do? And it's a totally different conversation than, okay, we're having this problem and this is how we're going to do it, and you're going to do it this way. It's an entirely different leadership style. That's not me.
So you only use Lean for the bigger projects, but you use it for the minor projects or the minor feedback, like solving where the printer should be. That is something you just get their input from, but you don't necessarily need to use Lean.
So Lean is more of a systematic use of these tools in your leadership. I use it systematically in my leadership style. I don't use every tool every day. I pick. And one of the key tenets for this is really the respect for the people who are doing the work. when you're making decisions about workflow, sometimes it's easy to not have it personalized to the people doing the work, but you have to remember there's a person on the other end of that who has strong feelings about how their work gets done. And it's having the respect for those people when you're having to make the hard decisions, because sometimes you have to. But if you've built that respect with the team over time, then you've built up that engagement and that relationship between the two of you, and you're able to have better conversations about the hard things when those things come up. So another thing that we do, huddling is a lean tool that we use. The COO wants us to do it every day. I lead 8 teams. I can't huddle every day. So we huddle with our teams once a week. Each modality has their own modality specific huddle. They have their own dedicated time. We huddle with third shift as a group, and we huddle with second shift as a group. And then all the first shift modalities have their own huddle. And they know it's their dedicated time with us. So if there's minor things that are coming up, somebody is making a list to bring up during huddle. And if it's something that can't wait, we all have open door policies, so they'll just bring it to us or stop us in the hallway or whatever. But you take that one step further into cross huddling. So what that means is we have our dedicated time with our departments. All the other leaders in the building have their dedicated time with their departments. But if I have an issue with pathology that involves pathology, I can't solve pathology's issue as much as I would like to. That's not my team. I can't, I can make suggestions, but I can't solve their workflow issues. So if we have an issue with pathology and we need to understand why they're doing something, then we invite somebody from the pathology leadership team to our huddle so that we can talk through that. And depending on what the passion level is of the team, a lot of times I'm the one asking the question, because I know what the question is. We've brought it up and we've made an arrangement for them to join our huddle, so that I'm framing the question. I've warned the leader ahead of time, this is what we want to talk about, so that they're prepared, so that then we can have a conversation with someone from that team to explain why they have to do whatever it is, the way it is. Another one is I went to our total joint floor because they were getting aggravated because our x-ray team was calling them first thing in the morning. When the first shift came in, we had all these orders to do on the total joint patients so they could be discharged. And we prioritize patient discharges, so we want to get them done quickly. Well, they haven't had all of their physical therapy yet, so they weren't ready to come down to the department, and the nurses on that unit were trying to understand why we kept calling them every day when it was too early. And sometimes the providers timed the orders. They wanted it done by 8 a.m., so we're trying to get that done. And so we had a really good conversation with them in a cross huddle and helped me understand everything they had to do. And we had a great conversation about, it doesn't matter what time, the provider just picked a time, and we created a workflow where we'll call the nurse first thing in the morning and say, I have orders for 801, 802, 805, 807. Are there anybody else that you know are going to need x-rays before they go home, to make sure we have everybody on our list? And then we write down the nurse's name and their phone number, and then the nurse will call us later in the day whenever the patient is ready to come down for their x-ray. And we were able to make that workflow through cross-huddling, because we were trying to do what we needed to do, they were trying to do what they needed to do, and we were aggravating each other in the process.
Also, we just utilizing 2 different departments on what over the workflow, what would be better for the nursing, the joint, and then the radiology.
Yes. And how can we work together to get everybody's workflow done in a way that works for everybody? And it helped build the relationship between the two teams. It really is a great tool. And it also helps that the majority of the leaders in the hospital are in this group and are familiar with these ideas. It helps facilitate a lot of things. Not all the leaders are, but it's a tool that we all use. So if we are having concerns come up about another team, or we just have questions, why do you do this way? Because that's having this impact on us. It helps us talk through those things.
So it's like someone from the head of that department?
Yes.
Maybe in your you're leading your meeting?
Yes.
Okay.
Maybe I'm getting ahead of myself here, but I stepped into an environment that had a very toxic culture, to be honest. A lot of the team had been penalized, in fact, for trying to proactively bring solutions and ideas to the table. And so, I've been there for about 10 months, and I've shifted the culture, and I've done that in partnership with some other wonderful people that I work with as well. But if I would have tried to walk in and I would have laid this down, there's no way it would have been adopted. So do you have any tips for how to kind of systematically maybe work towards something like this? Or do you think it's possible to truly just sit a team down and say, this is how we do things now?
So I think if I were going to systematically start from scratch, I would start with developing team huddles with my team. And then I would start seeing where the pain points were with other departments and building a relationship with that leader so that in a couple of months, it may take a while, but of building that relationship, you can say, hey, I meet with my team this time. We're having some questions about the why of your process because it's having an impact. Would you mind joining us to talk through that, to help explain that? I think it would mean a lot. And it means more to the team to have it explained by the other person. They're not getting it filtered through me. They're getting it straight from that leader. And it takes a lot of trust. And, like I said, when there's high passion about something, sometimes I'll let the team ask their question and sometimes I ask it for them because I want it phrased in a way that's not going to make the other leader feel attacked. And if I know it's going to be high passion, then I warn the team the week before, like, okay, we've got the leader from this department coming next week for huddle. Be thinking about the questions that you want to ask them, but please remember to be respectful. This is not an attack. I don't want them to feel ambushed, but we have genuine concerns that we want to talk through, and just slowly start doing that. And then it has genuinely helped build some strengths between us and the ER and us in the laboratory. We had a project where the lab wanted us to fill out a log sheet every time we dropped a sample off, even though our department was extremely consistent with marking it collected in the computer system. And so we just asked the question, well, why do we have to do that? And the original response back from the lab was, well, because we have issues with departments not collecting it. Like, well, can you run the data on that to see if it's any of our teams? Because if it's not our team and that's not a problem you're having with us, we would like to opt out of having to sign the logbook. If we're not giving you everything you need consistently, then we want to know that so we can do that. But we knew we were. And so they're like, yes, we can do that because we keep a log of all the things that weren't right. And we were able to sit down at a table in a conference room and really talk through those and do through some give and take. We were able to eliminate the entire logbook for our team. The whole rest of the hospital has to fill it out because they're still not doing it correctly. But I was able to eliminate that step for my team, which was a huge satisfier.
And so like you're kind of modeling for them then how this is done and what this sounds like. I found that I had to even teach them to ask questions. I had to teach them to say, okay, this is how we've always done things, but why?
But why?
Why?
And not only asking.
Does that mean we should keep doing it?
Correct.
But I mean, this is so organized, and I would love to do something like this.
Yeah, and getting them to not only ask why, but ask why multiple times for the same issue. Well, why do we have to do that? Well, because of this. But why is that? And then you ask why. It, like, sometimes you have to ask it 5 times to really get down to the root problem that's affecting your big problem over here, but also a couple of more up here. And if you can solve the root problem, then you've really done something huge. And so asking why is important, but you've got to be able to train your team that you're willing to hear the why. Ask me why. It's okay.
That's a good point.
Yes. And doing this consistently, and even if you start with the small things that are easy to say yes to, that are totally within your control. And then they will see you take their suggestions seriously, and that you value their input. And that is huge in building trust with your team. It's huge. And so for our 5S, for those who don't know, is a systematic way to organize a storage room. The S's, we have definitions on our homepage as well, and I printed them out because I knew I was going to get nervous and forget them. So sort/scrap, straighten, scrub, standardize, and sustain. It's what the 5 S's are. And really, you empty it out, you organize it. Everything has a home. And a lot of times when this is done, there's tape on the floor marking the boundaries for this cart goes in this space. And then when you get it done, you take a picture of it and post it on the wall. So when that cart leaves the room, when somebody new brings it back, well, where does the cart go? Well, the picture on the wall says it goes in this square right there. And then you don't have some supplies here, some supplies there, some stored over here, all the same supply. And then somebody comes to you and says, well, we don't have any, when you really have it in 3 different spots because there's no standardized place to put it. And so that's another tool. Gemba is a word that means going to where the work happens. So if you're going to do a process map on how we order supplies in our interventional radiology department, because that was a broken process, we did this. We did it with Post-it notes across the wall. And we mapped out every single step with the people who do the work as it happened. So what is your first step? What do you do? And then, okay, once you've done that, what is your next step? What do you do? And then we mapped out all of that. And then once you have it mapped out, you're trying to identify the waste. Where is the wasteful steps that are eating up time? And how can we eliminate those? And so a waste walk goes with Gemba, but you're really looking for defects, overproduction, waiting, non-utilized talent, or somebody's not working to the full extent of their credentials. Transportation, inventory, motion, and extra processing. We added motion in twice with a different name because it met the acronym downtime. And that's what our COO has in place for us. And then, you know, there's more. I'll pass this around too. Elevation goes with cross huddles, because if there's an issue that I can't solve, I've got to elevate that either through my leadership line or to another leader of another department. And so for our idea generation, we really use huddles for that. And for process improvement ideas, I can come up with them, but I'm not really interested in doing my ideas because of the benefits using the team's ideas have. So we have the philosophy that it shouldn't come from the leadership. The ideas should come from the frontline teammates who are doing the work. And so how do you get that out of them? Sometimes we go to huddle and nobody talks. Sometimes we go to huddle and everybody talks and it takes 45 minutes. It's not supposed to take 45 minutes, but when it does, it does. And so it's going to be quiet for a little bit. And so if it's quiet for a couple of weeks in a row, then I'll ask, what gets in your way? What's getting in your way for doing your job? And usually I'll get 1 or 2 things. I'm like, great. We capture those on the idea prescription card that is all the way at the end. If what gets in your way doesn't give me any answers, then I change it up and I ask, what's annoying you? What is annoying you this week? Because I know something is, so what is it? Sometimes it's something we can use for an idea, and sometimes it's just a venting session that we try and get through quickly and get back to work. But if it's something that we can use, then I want to fix it so that they're not annoyed. And so the idea prescription, anyone can fill it out. If I'm filling it out, then I usually fill out all the lines. If a teammate's filling it out, we only ask them to fill out these top 2, these gray spaces. So you can't read it, I'll read it to you. At the top is an idea title, the author's name, and the department. Because we're over so many modalities, did this come from CT, ultrasound, who did it come from? And then what is the problem? And then they can be done. They can fill out the other parts of it if they want to, but they don't have to, because I'll follow back up with them. And so why do you think it's occurring? What are the obstacles? What do you want to change? What do you want to experiment? And what do you think will happen? At the top is the date committed and date closed. And then these go along with the columns and rows on our huddle board. At the bottom are places for follow-up for me to write. So as I'm working on this, I'll jot a quick note, email sent on what date. And then I post it up. We have a giant dry erase board in the hallway. And I post this on there so that if the teammate's curious about where their idea is in the process and what I've done with it, all they can ask me about it, or they can go to the board and see where we are. And if it's been a couple of weeks, they know I'm open. Please remind me. Come back and ask me. And so the huddle boards, we have to have all of these items on it, but it's up to us how we want to organize it at the department level. And each department has it done a little bit different. For us, the top bullet points are our rows and the bottom ones are the columns. So we have our very top high priority issues across the top. Under that is people related issues, quality safety is under that, and then customer experience is under that. And then in the rows, we have the ideas. So ideas that have been submitted, but we haven't really done anything with yet. The next column is things that have been implemented, but aren't fully complete. And then I have a complete column. And we leave things in the completed column for a while, just to remind folks of the things that we have done and the changes that we have been able to implement. And then there's a parking lot. And the thing that's living in our parking lot right now, I believe, is can the hospital get a coffee shop? I'd love that. It would make me very happy to have a coffee shop in our hospital, but it's totally out of my control. And it's totally out of a couple of people above me in leadership's control. So we have that in the parking lot because I can't really affect that change. I value it, I agree with it, but I can't do anything about it. And so we use those cards to track ideas, and if I've got a lot of things going on, it reminds me, oh yes, I need to follow up about this one. And as you're going through them, it's always about the respect for the people, always about the respect through all change management. So the problem that we had in fluoroscopy was we had the lowest outpatient satisfaction score in the department. And so we switched from one survey system to another, which gave us the ability to break X-ray up between X-ray and fluoro, which we didn't have before. And then fluoro was way below everybody else. The question we were tracking across all the departments is would recommend this facility to others. That's our main question that we really were tracking. But fluoro also really was below in staff explain things. This is outpatient satisfaction. Yes. Yes, not the employees. The outpatients were filling this out after they had been home for a week. They get a survey. So my office is strategically placed right across the hallway from the X-ray fluoro control booth. So I can hear them. I don't have to ask them if they're explaining anything to the patients because I can hear them do it. So I knew they were explaining things. And whenever it was something that involved an APP, the APP would come and explain the procedure to the patient. These were the same APPs that were explaining interventional radiology procedures, which had the highest score in staff explain things. And that was mine, but we couldn't figure that out. And so we're like, okay, well, we can't figure this out. Great, we'll bring it to huddle next week. So we brought this, we had the graphs, we showed them their scores compared to the rest of the department and asked for ideas. Why do you think this is happening? We hear you, explain them. So I know that's not the issue because I hear you do it. But there's a disconnect somewhere. So what are your patients telling you? What are you hearing? Why do you think that's happening? And so my most tenured fluoroscopy tech, we float everybody through everywhere, but she loves fluoro. And I love her response. Her response was, I don't really know anything about that. I don't have any ideas for that. But can I just say I am super frustrated because all of my patients don't show up on time. They're either super early or they're super late or they don't come. And I am behind every day and I can't efficiently get the inpatients mingled in between the outpatient appointments. And I was like, okay, we can pivot. We can talk about this. We don't have to talk about satisfaction today. We can pick that up later, because she was really passionate. And so they were wasting time waiting on people who weren't going to come, because if they came, we wanted to fit them in. But then after we wait the 15 minutes, now it's too late to send for an inpatient because I got another outpatient who's supposed to be there. And so she was very, very stressed and very, very frustrated. And so her next sentence, she came up with her own solution immediately. She had a solution prepared. Can I call them myself and give them reminder appointments? And I'm watching the rest of the team because I have all generations in my team. We have a wide age range in our X-ray team. And the more tenured folks were like, oh, okay, yeah, we can probably do that. The newer technologists from the younger generations were horrified at the thought of having to call the patients and go through that. There was real anxiety. And so we worked through that. But in the moment, they were like, oh my God, she's going to want me to do that. I can't do that. And so in the moment, the next thing I said was, yes, there's no process needed. You want to call your patients, I'll let you call your patients. Yes, please call them, because it's a real issue. And so the first question immediately was, well, isn't that a HIPAA violation if we call and leave a voicemail? If we don't get them, can I leave a voicemail? Isn't that a HIPAA violation? And so immediately I said, okay, it is not a HIPAA violation depending on the words you leave on the voicemail. And you know this because you get reminder voicemails from all of your doctor's appointments. And how do they sound? They're very generic. Really, you don't have anything but the office that's calling you and the time you're supposed to be there. And so they're like, okay, well, if I have to leave a voicemail, what callback number do I leave? I don't want you to do that. Please don't. I don't want them to call back. Because when they call back, once my schedulers leave, the phones ring over to the second shift lead, and he doesn't want to answer scheduling phone calls at 5:30 when he's trying to clean up the ER that's exploded. So please don't leave a voicemail. They're like, well, what do we say? I'm like, it's super easy. You can say a quick prayer before you call so that they don't answer the phone, and all you have to do is leave a voicemail. I'm okay with that. It's fine. So all you have to say is, this is High Point Medical Center calling you to remind you of your appointment tomorrow. Please arrive in registration at 7:30 a.m. to get checked in for your radiology appointment. Hang up, click the end. You're done. That's all you have to say. And they're like, okay. Still lots of anxiety. And so we created standard work. I created a script for them. I'm like, you don't even have to think about what you want to say. It'll be on the piece of paper and it's fill in the blank. All you got to do is read what's on the paper and then hang up the phone. It's okay. And that made sure everybody was telling them the same information. They could use whatever verbiage they wanted, but as long as the bullet points that were in that paper got addressed, then we were happy. It covered everything we needed. So I built a script. I made sure it included the arrival time for them to check in and registration. And then we use Epic for our EMR. So I built a department appointment report in Epic, which is great because if you're familiar with Epic, some of the reports in my reports you run take forever to run. They're not instant. You have to wait for them to go. And that wasn't what I wanted. The department appointment reports generate immediately. So I customized one because I had built one for interventional radiology before. I pulled that, customized it to include the patient name, the exam that they were having done, the time of the appointment, and their phone number, which is really all they needed. So I got rid of all the other information. I left a big column for them to be able to make notes in, and then gave access to it to everybody and asked them to print it out every day. I showed them how to change the date to get to tomorrow's. They printed it out, and I said, as you're calling people, you can just check them off. so that you know who you've reached and who you need to try back and reach again at the end of the day. And they took it an extra step to where they would actually write on it, LM for left message, spoke with patient, spoke with mom, no voicemail full. So I knew what type of contact happened, and then I saved all of those. I told them I wanted the form back because I wanted the accountability to know that it had happened. And I didn't really care who called the patients as long as the patients were called. And they were quite happy to let the lead tech do it. Well, she works 4 9-hour days. And I've got a group of 5 of those, and they rotate their day off. So every 5th week, they get a Friday off, and then their next day off is a Monday. So they get a long weekend. Her first long weekend that came up, nobody called the patients. And I knew this because it was towards the end of the month. And when I ran, we started calling people in April. I kept all the papers through May. So when I ran the report in June to see how many no-shows happened, we had 6. So then I went back to cross-reference the days. 4 of those 6 were on the days the phone calls should have happened on the days she was off. So another lean concept is to remind everybody of the why of what you're doing and to celebrate the wins. Only having 6 no-shows was incredible. That was a giant win. So we started there. Look at the graph. You guys did great. We only had 6 patients not show up. And 4 of those 6 were on the Friday and Monday that she was off because nobody called. They were like, yeah, those days were awful because they had gotten used to people showing up on time. They're like, those days, they were so bad. I'm like, I am so sorry. But I feel like we need to create some ownership on who's going to make the phone calls. Because if she's not here, it still needs to happen. So I'm going to assign this task to the person that is assigned to fluoroscopy for the day, and all the teammates rotate through. Again, my youngest folks were really, really anxious, but they had suffered through those hard days and were like, okay, like if you need me to sit next to you while you call patients, you just come get me. I'll sit next to you. And I reminded them, you don't actually have, if you get a live human and they ask you a question, I don't need you to even know the answer to their question. All you have to do is say, that's a great question. Can I please put you on hold and I'll find out. Click, put them on hold. You don't even have to wait for them to give you an answer. Just put them on hold. It's okay. It's okay. So we did that. I sat next to somebody. This very young person got a very demanding patient who didn't like the time she was scheduled and wanted to change her time. And we couldn't do that because it was an arthrogram that has to happen with MRI with a very specific time. So we couldn't change her time. And I coached her on what to say to the patient and the things that we could offer. And she did a phenomenal job. And going through that, she was like, oh, if I can handle this lady, I can handle everybody else. It's fine. I'm like, yes, exactly. It's okay. So lots of hand-holding happened, lots of support, but they knew that we were there for them. And now everybody calls. And at the end of the day, I still don't care who calls the patients as long as they get called. And if you can convince somebody else on your team to call the patients for you, they trade off tasks. I'll clean your room for you if you'll call my patients. And they barter and trade, and as long as it all happens at the end of the day, I'm happy. So it's about supporting the data, showing them the data, celebrating their wins, circling back, reminding them of the why, and it'll cement in what you're trying to do. So we had 2 common outcomes of this phone call. I had no idea about this appointment because we scheduled it with the office and the office didn't tell them. What is it for? We have a bariatric clinic who orders a lot of fluoro studies, and the patients have so many appointments, they get them all confused together. And a lot of these people were not showing up because they were scared to death of having an endoscopy, which I wasn't going to do. So we were able to tell them, oh no, I'm not putting you to sleep. I'm not putting anything down your throat. All you have to do is drink some stuff, and then you're good to go for the rest of the day. You can go enjoy your day. And we started getting those patients in at their first appointment rather than their second or third, which then meant they could have their surgery. If they were a candidate, they could have their surgery faster. And we are the only fluoroscopy unit in our city. There is no outpatient fluoroscopy in any of the centers. We're the only one. We have 2 cities 20 minutes away There's options patients can go to if they don't want to come to us, but in High Point, we're the only fluoro unit. So we are fully booked 2 weeks out. And if I have large numbers of people who don't show, those are patients that I could have gotten in that need to have these studies done. So patients were able to speak to the technologist that was actually going to do their procedure or have done the procedure, so they have that knowledge and they could answer all of their questions before they showed up, so they knew exactly what was going to happen. Or option number 2, that appointment was supposed to be canceled. The office didn't call you? No, they didn't. Thank you so much for letting me know. We'll go ahead and take care of that and cancel that for you right now. Or I'm not coming. I don't want to have this done. I can't afford the copay, you know, whatever reason they're not coming. Or I'm not feeling well and I need to reschedule. Okay, great. Thank you for letting me know. Let me go ahead and transfer you up to our scheduling team and we can get that rescheduled for you right now. I can't fill that appointment because we're only calling the night before. But what it does is allows me to know this person's not coming and I have a hole in my schedule that I can pull an NPO inpatient down really quick and get squeezed into my schedule and not make them wait until the afternoon. And so we were able to efficiently move through the inpatient list and the outpatient list because I knew when people weren't coming because they told me they weren't coming, which is great. So part of our idea cards, we track those outside of our department using an idea catcher. And so this is my quick description of what I put in. We started calling people on April 25th, I believe. And so halfway through May, I submitted this because I wanted to have a little bit of data to go with it to validate that it was going to be a effective change. So we said, you know, current state, patients either show up at their appointment time or after, or don't show up at all. It's creating bottlenecks in throughput. We want to call the patients to remind them of their appointment and tell them what time to arrive. And then there's our average no-show rates through January through April was 11.25 per month. People didn't show up. May 1st through 15th, we had 2. I estimated halfway through the month that we would have 4. We had 6. But as of May 15th, our no-show rate decreased by 30%. That was just the first few weeks. We asked the finance team what our average reimbursement rate for a fluoro outpatient exam. It was $441. So if 7 people on average every month kept their appointment, that was just over $3,000 a month that we were able to collect or had the potential to collect that we would have missed because it would have been lost to no-shows. We do not. So I kept all of the papers. And because I wanted to track what are the outcome of all of the calls. How many people did we speak to? How many voicemails did we leave? How many people we weren't able? So what is the percentage? What does that look like? So the 51% in that dark green, we spoke to those patients or their family member. The yellow, the 34%, those are voicemails. The blue, the 12%, we weren't able to leave a voicemail or the wrong number was in the chart or we didn't make phone calls that day. This little sliver of green, the 3%, those are patients that we talked to that wanted to reschedule. And so then I took a look specifically at the patients that didn't show up and what kind of interaction did we have with those patients. So the blue again is I'm sorry, it's this one. The 18% is we spoke to those patients. And they still didn't come anyway. The 18%, this screen right there. Correct. Okay. And so there were 54 no-shows. This is a percentage of those 54 no-shows. The yellow, we left voicemails for. They didn't check their voicemail. Or they checked it and they still didn't come anyway. This 24%, we were unable to leave a message. The green, we didn't call people that day. and the 6%, the orange, had no number in the chart. But what I found very curious was the pieces of the pie. If you loop these, the green, the blue, and the orange together, it's identical to the 41, or it's very, very close. So it's the same number of people didn't show up that we left voicemails for, the same number of people didn't show up that we didn't contact at all.
Phone call the only thing that you guys do, no text message, no email reminder.
Correct.
So do you feel like phone call is more successful than, I'm just asking because
Yeah.
we're doing, that's what we're doing. We have orthograms
Mhm.
and trying to fill those slots.
Mhm.
No short last minute is a headache.
Yeah.
So we're kind of like, you get a text message, you get a,
Yeah.
right after your appointment, you get a message, you get one a day before, you get email, like, where
Yeah.
do the patient own the responsibility?
So we self-selected out of automatic reminders because most of these patients have multiple appointments in the same day and they were getting confused on when they wanted to come. So we stopped it. We're like, nope, stop, don't send reminders. So the outcome of the calls, I'm almost out of time, so I'm gonna go fast. The outcome, we spoke to these patients. This bottom green is folks that rescheduled. Blue is people who showed up. Yellow is no-shows. And 25% of the people we didn't contact didn't come. The people that we contacted came. And this is our no-show rate comparing 2022 to 2023 by month. We reduced our no-show rates by 40% just by calling patients. They do. They get a lot of phone calls. Yeah. So our hypothesis was correct. It worked. It was a successful project. Our patient volumes increased. Our no-shows went down. Our schedule runs more efficiently. The team is less stressed. And they know we take their suggestions for improvement seriously. And now they're more likely to speak up in the future. So there's some revenue we were able to capture revenue, but really I want to get to the outpatient satisfaction scores. So here's our map, 2023, would recommend. There's other issues happening, but we're trending up. And I ran this data yesterday for January 2024 through yesterday's date. We had 16 responses. They were all 100%. We won't stay at 100%. Somebody's going to be upset. It's fine. I'm not expecting to stay at 100%, but that's huge. You can see the positive trend going. Yeah. So this is before we started making phone calls. Our score was 77. The benchmark is 88. That's what our benchmark is. We're not there. We have more work to do, but we are well on our way. We increased our outpatient satisfaction score specifically for would recommend 6.9%, which in an outpatient survey result is tremendous. It is huge. And so the yellow bar is from the time we started calling patients through the end of the year. That's what the satisfaction score was, pulling this before we started out. And then the blue is the combination of the two. And our patients really appreciate having the opportunity to ask questions because they're still confused on what they're coming for. Because a lot of the times we're scheduling these exams with the office because the office is calling us to make the appointment and they're not. Or they're getting 6 appointments at the same time. You've got to come here and here and here and here on these days, and they're getting them all mixed up. So. But, you know, we started asking for solutions to solve this, and we immediately took a left turn, solved a different problem, but then we also worked on this as a byproduct of solving the other problem, the patient's not showing up on time. And it was a huge satisfier for them. I would, throughout the year, I would print this out and show them, here's your progress. Take a look at these graphs. This is tremendous to see where we were last year, this month, and where we are this year. And that really helped motivate them to keep going.